Good afternoon, everybody. I'm happy to start this webinar on challenging cases in lamellar keratoplasty. And I will be happy to introduce you the speakers of this webinar a bit later on. However, I would love to give the first word to Moria, to Ludovic Desno, who will say a few introductory words, please.
Thanks, Professor Michaud, for moderating this session about challenging cases in keratoplasty. And we are very happy to have also the other speakers for the webinar. So I'm here and I let you run the session.
Okay, so I would love to share my screen in order to introduce my co-moderators at that moment, Dr. Michael Attenborough, who will be talking about PK and VILK. Michael is from South Africa. Dr. Eric Gabisson from France, he will be discussing about ALTK indications and technique in the high volume keratoplasty hospital. Dr. James Myerscough from England will talk about tectonic mini DSEC for corneal perforations. And I will close this session with the case of DMEC for post-traumatic endothelial decompensation. So first, I would love to introduce Michael from Cape Town, South Africa. He was trained in Moorfields Eye Hospital as a corneal specialist for several years, and he's a very good, having a very good experience in anterior segment reconstruction, lamellar corneal surgery, and did some research on corneal biomechanics. He made a lot of transplants, so he gained a lot of experience in that kind of surgery, and was attending different ophthalmology congresses all over the world. So please, Michael, we are looking forward for your experience.
Well, thank you so much. Thank you so much for your kind words and your introduction. So, in short, my life revolves around the cornea. I'm probably not a very intelligent ophthalmologist anymore because behind the endothelium and sometimes the posterior capsule, the rest of the eye doesn't exist in my life. Thankfully, we have other trained specialists who can deal with that part. But for me, the cornea is what I deal with every single day. And Moria has been a game changer for me. So what I'm going to speak about is basically anterior lamellar surgery and penetrating keratoplasty. We all know that endothelial keratoplasty has come on a huge long way in the last 10, 15 years, massively so. And since DMEC, it's lightened the load massively. But my talk today is about using the Moria trephine system combined with artificial anterior chamber for a number of reasons. So the question is why do I use this system? Well, we all want perfect results for our patients because as corneal specialists, we all unfortunately suffer from obsessive compulsive disorder. And there's a few problems here. It's that the patient is a human, the surgeon, importantly, is a human, and we mustn't forget that we are fallible and we do make mistakes. And the corneal donor tissue also comes from a human. So there's a genetic mismatch here, which you can't predict. So there's lots of imperfection intrinsically in lamellar corneal surgery and full thickness surgery. So we've got to do what we've got to do to try and mitigate all of the levels of imperfection. And this is where Moria and their system really helps provide a very, very, very high degree of, I call it perfection for our transplants. So personally, I've been doing a lot of keratoplasty in the last 15 years. And here's just a picture from a few weeks ago where I did 9 transplants in 2 days. So it keeps me pretty busy. And so it's very stressful having to perform this high cost, high risk surgery, often in patients who only have one viable eye. So the reasons is quite diverse in my setting. And as I said, thankfully, DMEC has taken a lot of our problems away. But there's trauma, there's massively ectatic corneas, there's perforated corneas, there's only eye corneas with failed limbal cells. And also, if you see in the top right, there's one of my patients from a few years ago who had a dog who fell over, hit his head, and popped his graft off, but his Descemet's membrane remained intact. And I managed to take that graft off and just clean it up with povidone iodine and suture it back on. And today he's back to 2020, believe it or not. So keratoplasty definitely from the front is still an important thing. So why the adjustable trephine? So here in this diagram, you can see the standard non-adjustable trephine, and on the right-hand side is the adjustable. So for me, the adjustable is very important because I like to preserve the patient's endothelium, if at all possible, by doing big bubble or very, very deep lamellar surgery. So what I do is I've got an MS39 anterior segment OCT, and I measure everything that we do before and after. So we can work out the diameter of the trephination that we need, and we can also work out the depth at which we need to trephine I like to trephine about 80% of the depth to allow me to do the second part of the big bubble. Also, in certain corneas, when you're not going to do a big bubble, you want to have a very predictable depth, as the last thing you want is a perforation, because it often changes what happens next. So once you've done your measurements, you need for this case, I needed an 8mm diameter, and you can simply dial the trephine to the depth that you want. So I wanted to go 550 microns of depth for this patient. It's very easy to see. The movements are very smooth. That trephine is made so beautifully. It just works smoothly every single time. And I just like to say that I have no financial interest in Moria, and Moria has no financial interest in me. This is purely my experience. And so for this patient here, that is after I've done a trephination of 80%, and that is the Descemet's membrane lying over there. So once we've got our depth and we do all the things that you don't need me to bore you with big bubble techniques, etc., we can get a perfect host cornea to take the next step in getting the donor tissue in. So there's the result. So as you can see, if you look on the left-hand side, is perfect lining up both in angulation and in depth and in size. And this is literally a week after surgery. And this patient hopefully should maintain good endothelial health. And once the stitches come out, should achieve really good vision down the line. The other advantage with the Moria system, which I find is greatly lacking in other commonly used systems around the world, is that the alignment system is so amazingly good. There's a thing called the error of parallax, and when you're trying to line up things in a vertical fashion, often if you've got the error of parallax incorrect, you're going to be off-center, and an off-center graft is not optically what we want. You can see here, so here I've marked the dead center of this cornea. As you can see, it's nowhere near in the middle of the pupil. So I often take a Calibri forceps. I use a Moria Calibri forceps, and I push a dent onto the cornea. So you can see that little circle in the middle. So here, I'll show you exactly what I see down the microscope when I'm using the alignment aids. So if you have a look here, and this is what we see, it'll go a little bit dark in the edge because of the video camera on the microscope. But if you see that circle there, is so easy to line up with the middle of the trephine. And even if you wobble it around, etc., it stays very, very central. So we just release the vacuum, and which is amazing. And once I just wobble it around a bit to make sure I've got a good suction, and then I dial the trephine to, in this case, this was for a PK. So what I do is I dial it very slowly and carefully, and the suction system is so precise but gentle. And as soon as I see a little bit of aqueous appear, I stop to make sure that there's no trephinating of any internal structures, the iris, etc. So here you can see just very gentle. There's a little bit of aqueous there. So we stop, push in the syringe, release the vacuum, and there we go. So a little bit of air pops in into the anterior chamber. You can see there's a perfectly centered 99% thickness trephination. And if we just have a look, I would probably think there's a bit of a perforation superiorly. So if we just have a look a little bit further, we're able to see, here we go. I'm just filling a bit of the calibre there. There's the perforation there. So we can continue the keratoplasty after that. So the vacuum is also very, very efficient for the system. We often have to deal with very steep, ectatic, irregular corneas. But if we do this very, very carefully and with the alignment, and what I often have to do is I do a small paracentesis, a 0.8 millimeter paracentesis with a diamond knife way off in the periphery of the limbus, just to reduce the intraocular pressure. This often helps us get a really good vacuum. And as you can see, there's those 16 little suture marks as well, which help guide us with our suturing. The vacuum system helps us to get good fixation on very irregular corneas. So here's a before and after, and you can see there's really good alignment there. This is a patient with, unfortunately, fusarium keratitis, which we all hate. And this was the patient that had that, this is fusarium in a graft. So even with this horrible surface, the vacuum on that trephine is amazing at achieving that. We also have some quite crazy ectatic corneas which we have to deal with. Thankfully, scleral lenses save our patients a lot, but sometimes we do need to take them one step further with keratoplasty. And the patient on the left, also very, very steep. This is a physiotherapist colleague of mine and still working. It's quite amazing what people can do with their very poor vision. And we also have exceedingly globus corneas. So here you can see on my OCT, he has a massively ectatic cornea, but a little paracentesis reduced the pressure slightly, and the adjustable vacuum trephine grips that super, super well. And here, just to show you, I've done a screenshot so you can actually see I'm not making a joke. If you see, this is a patient of ours. Sorry, Elizabeth, you're an amazing patient, but she's given me permission to use her name. Just so you can see, this is the right eye of the same patient. It does not look like the same patient, does it? But it is, because the ability for that moria to hold on to that and centrally trephine is really, really good. Also, we've got a lot of difficult cases where the access is difficult. So here's a patient, that's his only eye. He had retinoblastoma as a child, blind in his right eye from birth, and survived till the age of 60 with his remaining left eye, which had stem cell failure, and eventually we just could not get any further. So he needed a Boston K-Pro. But unfortunately, the lids were stuck to the conjunctiva. He had some blepharon the whole way around. So this is already half an hour into the procedure, just trying to get his lids open. And with most regular trephines, it is really hard to centrate your trephination in an eye like this, needing a Boston K-Pro. So here, the second image on the right is basically a delamination of the surface, just getting the conj a little bit more flat. And then there's the trephination on the left-hand side. It looks all very wonky, but that's because the pressure has now dropped to 0. And I've done almost a total iridectomy, and you can see the retina in the back. And this guy's retina is amazing, because after his Boston K-Pro, this is on the table, after I've done the K-Pro, the next day, I am not joking, he read 1.0 on the chart. So without the moria ability to grip onto these very difficult eyes, it's difficult. So I also use the anterior chamber. So why do I do that? So we've always been taught, what to remove, replace it with something exactly the same size. Often when you're punching from the back, and moria does make an amazing punch. I mainly use that for endothelial grafts, my DMEX and D6, but the punch works very well. But you always have to adjust the size according to the size of your host trephination. But when you're using when you punch from the front, both on the donor and the host, you don't need to change the size of your trephination. So basically, you don't have to give any more or give any less. So that's why I use it. So essentially, you can create a pressure inside, once you've mounted the cornea onto the device, the donor cornea that is, you can, with a single syringe, it has 2 syringes attached to it, but you can just, you get used to getting intraocular pressure type of pressure on the cornea. So you also can recreate sort of anatomical levels of pressure on the anterior chamber, so that when you place the trephine, and I use the same trephine for the donor and the host. You don't need to use a new one. I'd use the same trephine for both of these procedures, and then discard it after that. It's exceedingly sharp and cuts absolutely perfectly. The advantages of the system is the centration is amazing. You basically, it's guided straight onto the system. You don't need to do anything other than dial the device, and you get a perfect cut every single time. What I would say is that 90% of the time you don't get 360 degrees of penetration. Often 1 or 2 or 3 clock hours is left unrefined. So I just tidy that up with a diamond knife to release it completely. But the cut is really, really good. And so here you can see just how well aligned the donor and the host are when you cut both from the front. And you know, here these patients are horrible, often, you know, severe infections, severe hot, angry eyes, and we eventually get them in fixed. So this is the same patient, you know, after a few months, the eyes quietening down, and we can get really good intraocular, vision for these patients even while they have their sutures in, because of the perfect alignment of the Moria system. And both myself, my patients, and also my staff, actually, because it makes me less kind of anxious in theatre, really thank Moria for this device, because it's made our life massively easy. And also our colleagues at the back of the eye like to have a clear cornea to view the retina, so it certainly helps us all, and our patients, I think, are really, really serviced by this amazing device, and I couldn't be happier with it as a product. So that's all I have to say. Thank you.
Thank you very much, Michael. Would you mind stopping and sharing your screen? Okay, yeah. Perfect. So he was obviously talking about different cases, penetrating, lamellar, very tough and challenging. And you mentioned the alignment. And so when I try to align my trephine, there is always a challenge. Should I align it on the pupil or on the limbus? And sometimes when the pupil is very much decentered, the choice is not so easy going. So having a vast experience in corneal surgery, what is your opinion? Should we aim on pupil to get the best refractive results, or should we better center on limbus?
Well, personally, I always try to be anatomically central in the cornea, so I don't use the pupil as a guide at all, because often the pupil is nowhere near the center, and if you're off by half a millimeter or even a millimeter, the aberrations you get from decentration of a graft, especially while the sutures are in, is quite high. So what I do is I basically look purely at the geometry. I measure from the limbus at 180 and 0, and from the limbus at 90 and 270, and I split that difference in half, and I cross it to get the dead center or the vertex of the cornea, and most often it's nowhere near the center of the pupil.
Okay, and obviously you're doing a lot of anterior lamellar surgery, and we know it's a challenging technique, especially big bubble. And there's a lot of variability in different big bubble techniques that we can use, visco, air, you name it. So what is your preferred technique? What would you love to show us and to recommend us?
Yeah, so I've very much am a big fan of the big bubble. So what I do is, once I've done my trephination of, I've measured my depth on the OCT and done that with the Moria device, I do a 50% lamellar dissection with a crescent blade, so it's sharp, but I do it in a blunt fashion. And in the second 50%, I use a sinicola cannula, and I go probably about 25% of the depth of that area and inject a big bubble. I probably only get a big bubble about 60–70% of the time. I need to get better at that, but often with 2 or 3 attempts at trying to get a bubble, you do get that. If I'm not sure about whether I've got a big bubble or not, I often put a small injection of air into the anterior chamber, and with those bubbles, if they decenter to the edge, then you know you've got a big bubble because of the posterior curvature of the decimers. But if I'm not sure whether I've got a big bubble, I will go on to doing a lamellar dissection. That was taught to me by Chad Rostron. He never did big bubble. He did all of his DRLKs like this, and it works fantastically well. And you're often left with maybe 20 to 30 microns of stroma on top of the decimers. But often these patients, their vision is so poor that that actually provides strength, and obviously long-term rejection is a lot less. So big bubble is my preferred technique, but if not possible, a deep lamellar dissection.
Perfect. Thank you very much for your tips, and these are all great, and I believe they will be very much helpful. Yeah. So let us introduce the next speaker, Professor Eric Gabisson from Paris, France. He's a Deputy Director of the Ophthalmology Department of Rothschild Ophthalmic Foundation in Paris. And he done corneal and refractive surgery fellowship in the US, and later on in Rothschild Foundation. And he wrote several book chapters and articles in peer-reviewed journals. Eric, we're very much looking forward for your talk.
Thank you very much, Professor Maluguin, for this introduction, and thank you, Moria, for this invitation to talk about automated lamellar therapeutic keratoplasty. I don't know if I... Yes. Oh, this is... What? Yes. So automated lamellar therapeutic keratoplasty allows the, do you hear me well? Yes. Allows the removal of disease anterior to mid-stromal opacity and of the corneal, letting clear and clear posterior stroma and endothelial layer. This is mainly indicated for superficial scars and anterior corneal dystrophies, but I'm going to show you that it's not always the case. This technique was made possible by pioneering work of José Ignacio Barraquer in the early 60s that allows mechanical lamellar dissection and allows the very clear and homogeneous interface that allows the restoration of vision. Among the different techniques, therapeutic photoablation is restricted to the treatment of only very superficial opacity and lesion of the cornea. deep anterior lamellar keratoplasty, as you showed previously, is necessary for the treatment of total opacification of the cornea or very big irregularity in the cornea. So automated lamellar therapeutic keratoplasty is important and is used to replace the anterior and mid-stromal opacification of the cornea. So it's important for the treatment of anterior to mid-stromal opacity with low to minimal rejection rate because it's lamellar keratoplasty and let the endothelium from the patient. Less stringent donor quality criteria because you don't need endothelial layer. This technique is less invasive. It's easier to be trained as deep anterior, for example, deep anterior lamellar keratoplasty, which is for me the most difficult technique with smooth donor-recipient interface, even for deep cuts and strong opacities. It allows early removal of sutures and less induced astigmatism. Femtosecond laser will never replace ALTK automated lamellar keratoplasty as photo description through opaque cornea and photo description in deep corneal layers will always let irregular interface. One of the limitations of automated lamellar keratoplasty is the treatment of huge irregularity of the cornea, such as in keratoconus and in pellucid marginal degeneration. In this case, deep anterior lamellar keratoplasty or more precise lamellar techniques are preferred. For the donor lamellar cuts, we place the anterior, the corneal graft with the scleral rim on top of the anterior artificial chamber, and we choose the head of the microkeratome depending on the clinical cases. But we can use thin head below 150 microns, and we can go up to 350 microns. For some cases. So as I showed you, the choice of a microkeratome head depends on the clinical case, and you're not obliged to take exactly the same head for the donor and for the recipient. And for example, in this case with thin cornea, I use a different head, allowing me to add some thickness during the removal of this opacity. Early and long-term results are usually good. For thin graft, we are allowed to use only contention suture that we can remove very early, as soon as 1 week. For deeper lamellar keratoplasty, we use conventional suture, and we remove them earlier than conventional graft, but still we let them longer, between 6 months and 1 year. You can see here in OCT cuts the clear and regular interface in this particular case. So it was George Bicop that was showing several years ago the overlay sutures allowing early removal when the lamellar graft is thinner than 150 microns, and when the graft are thicker than 150 microns, we use conventional sutures. Stromal corneal dystrophy is an example where automated lamellar keratoplasty may be used. Of course, for the most anterior dystrophy, photokeratectomy, therapeutic photokeratectomy is usually preferred. But after several episodes of therapeutic keratectomy, we want to add a bit of corneal stroma, and automated lamellar keratoplasty is indicated. In this particular case, you can see this elderly patient. It was a recurrence on an automated lamellar keratoplasty in which I do photokeratectomy ablation. So we have a lot of tools to treat these ever and ever recurring disorders of the cornea. So before and after treatment in this patient. One of the most challenging cases in the cornea is recurrent fibrotic scarring that may occur despite keratectomy, despite photoablation and even manual keratectomy. And despite the use of mitomycin C, we have some patients that recur. And for this kind of patient, even thin layer of stroma helps a lot. And it's one of the most challenging cases that we can deal with in wound healing, corneal wound healing. This is an example of patient third recurrence of fibrosis in the cornea. We remove, we treat with mitomycin C, and you can see 1 month, 2 months, 3 months recurrence of very huge amount of fibrotic tissue, and automated lamellar keratoplasty is the treatment of choice of this patient. So we can mixed recipient manual dissection. When you have a huge scar, you can always try to remove in the beginning, especially if the scar is irregular. And then if the corneal stroma is totally clear, like it will be the case in this case, you don't use the microkeratome to delaminate the recipient stroma, but in other cases, like in this case, it's a pediatric case, following the mechanical ablation, we still use the ALTK in the recipient cornea to remove very thin layer of cornea. It was the third recurrence of the fibrotic scar, and you can see the absence of recurrence over time using the ALTK technique. So these challenging cases maybe deal with this technique. New generation of intrastromal keratoplasty use also the automated lamellar therapeutic keratoplasty technique. And here is a tectonic mini graft. It was an intracorneal ring segment that was inserted in a keratoconic patient. And he had several years, I think it was more than 10 years following this insertion, a melt on one edge. No, it was not an edge on one part of the ring, and I used tectonic tuck-in graft. It was at that time Mark Muren that showed us this technique, and with the ALTK, it's very elegant, and without any suture, you can tuck this lamellar graft in the melt. Another technique that we developed in the department is intrastromal lamellar keratoplasty, sclerocorneal intrastromal keratoplasty for pellucid marginal degeneration. In this case, instead of suturing the lamellar graft on top of the cornea, we create a sclerocorneal pocket, and we customize the cornea. We create a crescent lamella that we insert through the pockets. And it's both increase the astigmatism and thicken the cornea without any suturing in the cornea. All the suture are placed in the sclera. So ALTK has evolved. ALTK is still present in our clinic, and will never be replaced by femtosecond lasers. So if we talk again of the indication, so severe scarring of the anterior and stroma and mid-deep stromal opacification with preservation of the 200 last micron of the stroma, abnormal healing following anterior keratectomy, anterior stromal dystrophy, management of flap complication. We didn't talk much about that, but it's very fancy if you have wrinkles that are very difficult to flatten, to change, directly change. You use the same thickness of the flap. You don't use suturing. You do overlay containing suture, and you can remove the suture very easily and quickly. Tectonic complication of keratolysis, and our silk intrastromal lamellar keratoplasty. So each time we get new fellows in the department, we are fortunate to go to Moria's facility, and you have an example with Ludovic, with Walid and Mark Kaikoya. They are training our new fellows in the department. With all of them, they have anterior chamber and everything to learn this technique that needs to be learned by cornea specialists. Thank you for your attention.
Okay, excellent talk. Thank you very much for this great talk, Eric. And obviously there are questions. And by the way, I encourage those who are joining us online to ask questions. Please feel free to do that. And my first question would be to you. So you mentioned that you're doing your automated lamellar keratoplasty in the range of the depth up to 350 microns.
Yes.
So you think that deeper lesions that may happen, they will require full thickness graft. So why is it 350? Why is that threshold?
Yeah, so I think there's a variability in the dissection. So if you let anyway, if the opacity is deeper than 300 microns or 350 microns, usually I use DALK, deep anterior lamellar keratoplasty. But in some cases in which I don't want at all perforation, because for example, if with DALK you get a type 2 big bubble, and you will have a very challenging dissection if for example the case is at high risk of rejection. Sometimes I prefer to use deep automated lamellar keratoplasty for even deeper than 300 micron to decrease the risk of perforation. But if the clear stroma is below 200 microns, I don't take the risk. I do manual injection.
Okay. In the meanwhile, may I ask you to stop sharing the screen?
Oh yes, of course.
So we will be able to see other speakers. The second question is that we know that lamellar keratoplasty was always considered to be having lower visual acuity as opposed to penetrating. I'm not talking about DILK, which might be a bit different, but lamellar keratoplasty obviously did. What we can expect from your technique? So what is the highest vision you get from the patients when you cut anterior lamellar automated 350 microns, 250 microns?
Yeah, so thank you very much for this question. So what I always say to the patient, it's always a compromise. If you want clearer vision, you take higher level of risk. If you want lower level of risk, maybe you gain less, but the risk is lower also. You know what I mean? So if you try DALK, you may have 20/20 vision at the end of the treatment. But with automated lamellar keratoplasty, you have between 10/20, 10/20, or maybe a bit more. But as I say to the patient, this is a compromise. I'm only talking about deep when I use a deeper, thicker graft than 120, 150 microns. When you use the thinnest graft, you may reach 20/20 vision. But you were asking, your question was about very deep and deep. If you use deep, the results are not as good as DALK, but the risks are lower. So it's a compromise depending on the patient.
Yeah, I agree. It's always a compromise in between the safety and the gain that you may potentially have.
And also, can I make a comment? Also,
sure.
As Professor Gabizon mentioned, not the benefit, but one advantage of the ALTK is that you don't require a very good cornea from the eye bank. I mean, you don't care about the endothelial density. It can be a poor density But by the way, the eye bank can provide this tissue and can be used.
Yes, particularly in this this time of we have a shortage of graft.
Because do you know the percentage that the eye bank can reject because of not enough density of endothelial cells? Is it 1/3 of the corneas? Is it?
In France, the total rejection rate is approximately 50%. I don't know in other countries. Yes, nearly 50%.
So it can help to use.
Not only for endothelial loss, it's a total rejection rate.
Eric, one more practical question. We know that the corneas that comes from the storage media might be a little bit swollen and have a higher thickness, and as opposed to the regular and normal cornea. Any kind of recommendations or whether or not there is a need of adjustment of the depth of the cut or whatever, or you just do it like it is? So what is your experience in that?
So it's an important question. For deep dissection, deep section, I think I don't care much of the difference. Even if it's 20%, I don't care. When it's very thin graft, usually I'm happy that the graft will thinner because it will increase the vision. So usually I use the thinner head in this case, and I don't adapt. I'm happy that at the end of the treatment, the cap will be the lamellar graft will be thinner as I expected. So yeah.
Okay, so in general, there is no need for adjustment of the depth of the size of the cutting head.
The other difficulty is the size. Usually I have discrepancy between the donor and the recipient. It's always, not always, but very frequent. So sometimes I adjust with a trephination. As you see, probably saw in one of my movies, you saw that I removed the peripheral part of the lamella.
Okay, that's good to know. That's good to know. Thank you.
And just one question, Professor Gabizon. When you were mentioning that the deep ALTK provides less good visual outcomes compared to DALK, how do you enhance? How do you plan the enhancement treatment for the patients at 1 year post-op? I mean, do you plan LASIK? Do you plan surface ablation?
No. Most of the time in this case, we don't plan LASIK because most of the time it's due to irregular astigmatism. We can do topo guided things like that, but most of the time when we choose this kind of treatment, we are happy with the results. And if needed, the contact lens may be used for. As opposed to when we do thin ALTK, we can lift the flap and do enhancement. If the patient, for example, has high myopia at the end, we can decrease that with like a LASIK technique, but without removing the cap.
Yeah, the tissue. Okay, interesting.
Okay, perfect. I think for the sake of time, we should move on, and let me introduce the next speaker, who will be presenting today. This is James Michaud from UK. He's a consultant ophthalmologist, having special interest in lamellar keratoplasty and refractive surgery. He completed his education in Cambridge and was working sometime with well-known Professor Massimo Busin from Italy. So we're looking forward to have James talk with us.
Thank you very much. Ludovic, I think you're going to put my recording on. I'm sorry, everyone. I'm rushing through an airport and it's very poor internet. So, Ludovic, do you mind putting the recording on that I've sent you?
Okay. So, do I run the PowerPoint?
Yes, please. Well, with the recording.
Okay.
everyone. Thank you for the So we've all seen this kind of patient in our clinic.
I think we need higher sound.
Corneal perforation with loss.
Okay. Sorry. The sound is at the maximum.
Who's inside? It's clear.
So we've all seen this kind of patient in our clinic with a corneal perforation with loss of the anterior chamber.
Is it okay?
Traumatic, infecting.
Not for me, maybe for the others is okay.
And the standard first-line treatment to
It's very soft.
is usually corneal.
It's pretty soft.
Yeah.
Yeah. Volume is at the maximum. So
Okay.
Any time of day in most departments, and is well within the competencies of a general ophthalmologist, albeit a usually temporary measure. So this is a man that presented to Southend Hospital about 3 years ago, having had an industrial accident and presented with a temporal corneal perforation secondary to a metallic foreign body that flew into his eye and caused a perforation with loss of the anterior chamber. The patient was initially managed with a corneal glue and patch, which could not successfully seal the perforation. It was repeated once more and still did not close the perforation. So this is the first time we tried mini DSEC. And you can see intraoperatively so far we have put some air in the anterior chamber, like with conventional endothelial keratoplasty, and then applied a patch just so we can make some space underneath the perforation where we can pull the graft to. And here I've punched a DSEC graft that's been cut with a linear Moria microkeratome system. I've just trimmed the edge just because I was hoping to manage to keep the corneal graft completely out of the 6mm optical zone. This is loaded into a Buzin glide and pulled into the anterior chamber with forceps. I prefer to pull the graft in rather than the other more recently described technique of tectonic DSEC, where it's pushed through the perforation, mainly because often a perforation has got quite thin, tapered, necrotic edges, and actually if you put anything through a hole like that, the only likelihood is you'll make it larger, which is why I think it's a better idea to pull the graft in rather than put it through the perforation. Once the graft is in place and put underneath the perforation, like any other endothelial keratoplasty, the case is finished with a full air tamponade, and in this kind of case, rather than doing a PI, I actually dilate the patient and lie them flat on their back for about 4 hours before releasing a little bit of air. And this is what the patient looked like post-operatively. Actually, this is about 7 or 8 months post-operatively, once they'd also had cataract surgery. You can see the anterior segment OCT there with the graft on the left-hand side. And you can see here from the corneal topography, actually there was only 1.1 diopters of astigmatism. And once this patient had had their cataract surgery, their uncorrected vision was about 6/7.5 with a best corrected visual acuity of 6.6. So this is the second case that we did. This is a young man with a background of herpes simplex keratitis. He's a difficult man. He's an IV drug user and only really comes to the hospital when he has a problem. And this day he did have a problem. He presented with a 2mm central perforation with bacterial keratitis superimposed on an area of thinning in an already densely neurotrophic cornea. And so we glued the perforation, and he didn't come to his appointment the following day, but presented about 5 days later with a flat anterior chamber again with a hypopion. And this is the case. In this case, we prepared a 6mm mini DSEC tissue and placed it under the perforation and just put it as central to the perforation as we can, accepting that it was well within the visual axis, but gave us a temporizing measure to get the eye safe before deciding what to do next. This is a photo from about 2 weeks post-operatively with corresponding OCT. You can probably see from the OCT that we haven't done a decimeterexis, and the interesting thing is essentially, in these cases and all these cases, we always find that the perforation itself acts like a natural vent. An atmospheric pressure almost sucks the graft out. So we don't perform a decimeter rectus in any of these cases, but we haven't had any problem with detachment. And I think that's just because of the pressure gradient that you get in desec and perforation. The other thing you'll notice is that thin layer of epithelium over the stroma, and actually within about 7 days or so, the cornea had epithelialized. So with this eye, we waited about 6 months for the eye to settle down and put the patient on some systemic antivirals. And once the eye was quiet and we had some availability of tissue, we proceeded with an elective rehabilitative treatment, which was a mushroom keratoplasty. For those of you not familiar with this technique, it's a 2-piece lamellar graft with a 9mm anterior layer and a posterior 6mm layer. The idea being that you maximize the refractive benefit of a wide graft whilst minimizing the endothelial replacement with a small posterior lamellar graft. And I'll show a quick clip of a mushroom keratoplasty. It's not from this case, but just so you know what I mean. So this is a video of mushroom keratoplasty, the technique. So the first thing is, as with any cornea graft, to mark the center and center the trephination on that. This is a slightly older video I've used here. I tend now to use the adjustable vacuum from Moria, Trefine. So the anterior lamella in a mushroom, we trefine to about 250 microns, and this is usually at 9mm. And then perform a peripheral lamellar dissection, 360 degrees around the cornea. And the nice thing is this gives a shoulder for the anterior lamella to sit on, and because it's manually dissected, there is quite strong fibrosis that happens, so suture removal can really quite comfortably be done by 9 or 10 months without worrying about any wound dehiscence. So once the anterior lamella has been dissected, we remove the anterior cap, and that just means we have a nice plane for the full thickness central trephination of 6mm. And now we prepare the graft. We split it into an anterior and a posterior lamella. Because the anterior dissection was about 200 microns, we use a 200 micron head for a mushroom, and this is preparing the anterior 9mm graft. And the stem of the mushroom is then punched to about 6mm, having marked the front like with a desec with an F. The nice thing about a mushroom is, especially in cases where the perforation is not central, the stem of the mushroom can actually be purposely decentered. And there's a case like that I'll show you shortly. So now the posterior lamella is punched to make way for the posterior lamellar graft, and that's to about 6mm. And usually this needs to be completed by hand, as you'll see here. So now you've got a peripheral shoulder of about 1.5mm width all around, a 6mm full thickness window, and then into this full thickness window place the posterior lamella 6mm, and that doesn't require any sutures. Once that's in, you put the anterior lamella on top, and you suture that in place. Usually if it's an infective etiology, I use interrupted sutures, and if it's a elective, non-infective and non-inflammatory etiology, I use continuous sutures. And just so you can get an idea for suture tension, I usually put air while I'm suturing, and then at the end of the case, to reduce the chance of pupil block, I exchange at least half of the air for BSS. And even if you take all the air out, the graft doesn't detach. It's something unique to mushroom, I think different to endothelial keratoplasty, whether it's the stroma-stroma interface, but the grafts don't detach even if you don't leave any air in the eye. So this is another case. This is a lady with keratoconus that had a PK and then got herpes simplex, and this was compounded by dupilumab-induced ocular surface disease, which she then ended up with a persistent epithelial defect, which then went on to perforate. And in this case, we did not have any spare corneal tissue that day, so all I had left was corneoscleral rim of a patient that had already of a graft we'd already used for a desec for another patient, and because we had this, we decided to use that residual tissue, and we just punched the edge of it just to get enough tissue to seal the perforation. And I won't bore you with another surgical video, but this is a one-day post-op video of the patient. You can see that semicircular kind of shrapnel piece of tissue in there with their epithelial defect over the site of perforation. And here's the picture about 2 weeks post-op. You can see again the graft itself is thick, and actually, although this is a small perforation, it's not so important about the thickness of the graft, but I would say in tectonic desec, especially if the perforation is large, then aim to have the tissue thicker than for a conventional desec. Aim for 250, 300 or even more in terms of thickness to prevent prolapse through the perforation. And this is the subsequent rehabilitative surgery for the patient you just saw with the shrapnel. It's a very long video and it's not very exciting because really it's just a triple phaco PK, but just to kind of complete the concept that this was initially a desec just to stabilize a hot eye, and then we went on afterwards to proceed with rehabilitative therapeutic keratoplasty, and it was just ending up with a straightforward PK, as you can see here. This is the last case I'm going to present. This is a young lady who presented with Pseudomonas keratitis with perforation, who was glued, and a similar story that the perforation was too large really to maintain an adequate seal with glue. And when she came back, we had done a DMEC that day, and this case really is just proof of concept that you can use any corneal tissue in tectonic desec. So we had tissue that already had the decimase removed, so it was just a full thickness stromal button. I didn't have the microkeratome in that theatre that day, so I used a full thickness internal stromal patch to plug the perforation. And you can see here the photo, including the OCT, quite how thick the donor is. The donor actually there really looks thicker than the recipient, and it is a full thickness edematous cornea without decimase. And the interesting thing about this case actually is when we then went on to do the elective mushroom keratoplasty for visual rehabilitation, I sent this button in to have a look, and histologically endothelium had actually started to grow on the posterior surface of the button. And this patient also went on to have a 2-piece mushroom keratoplasty, as we discussed earlier. So in summary, mini desects are quite a useful technique for this kind of eye where the perforation is too large to glue, although I still think it's worth trying glue in most cases as a first line. If the perforation is peripheral, the fact that it doesn't really contribute to the anterior surface astigmatism, it's often the case that no further intervention is necessary, although if it's an optical zone perforation, then it's a useful technique just to temporize things until the eye is sufficiently quiet to proceed with elective keratoplasty.
Thank you, James. Would you mind
Pleasure.
stopping?
I'm sorry, I think that video may have been a bit of painful watch. I don't know if it was going very slowly.
Okay, so I think this is an excellent technique. So James, thank you very much for sharing with us. And obviously, this interesting mini DSEC, as you mentioned brilliantly, can be used both as a temporary and a permanent solution, which is great for the permanent for the peripheral graft and temporary for the central located lesion. Do you think that graft thickness is critical? Do you pay any attention on the graft thickness, or you use whatever tissue is available, or you try to make it thinner? So tell us a little bit about your choice with that respect.
Yeah, I mean, with regards to graft thickness, I think if the perforation is not very large, the graft thickness is less important. And the whole idea of this really was born out of using redundant tissue from other grafts. So often you can't be fussy, but if the perforation is large, I would say you do need to have a thicker than that. You know, if you can't put a very thin DSEC into a large perforation, or it'll prolapse through the hole. And the other group, there's another technique for mini DSEC that's been described, putting the graft through the hole, and then they found that not only does that mean that putting the graft through makes the hole bigger, but because they haven't made the graft thicker, it prolapses through without sutures, and then you kind of lose the benefit of doing the whole thing if you're going to have to suture the hole on top of the graft. So the way around that is, if you do have a large perforation, then those cases it is important to have a thick graft. And you can see in that last case, I mean, you can even get away with putting a whole cornea internally. You know, it's probably not best to leave it there forever, but I mean, you can, a very thick graft, even with a large hole, will not prolapse. If the diameter is wide enough and the graft is thick enough, you know, even a large hole can be perforated, can be closed without sutures.
Yeah, absolutely. Interestingly, you showed us very nice OCTs of these grafts. And the next question to you, during the post-op observation, did you, in this quite deep perforation, did you see the graft melting, or you see the graft was intact? Was there any thinning of the graft in the post-op period that you observed?
Okay, so in those cases that I showed you, no, but I have done a case fairly recently with a tectonic DSEC in a patient with a rheumatoid melt, and I put in a DSEC that was thick enough, but that also melted. And with them, I abandoned ship and ended up doing a PK. So yeah, I have seen one case. I think probably that was the reason that one melted. It just did not reepithelialize. And to date, I've found that most of these tectonic DSECs, they do reepithelialize, but that one, I couldn't get it to reepithelialize, and the new stroma melted. So I have seen that once.
I'm checking now if we do have any questions from the audience, and it looks like we are not. And I want to thank James for the great talk, very insightful, and obviously very practically helpful. Yeah, thank you.
Thank you. Thank you very much.
Yeah, and let me continue to the next talk. Will be on DMEC for post-traumatic endothelial decompensation and iris defect. And here's the case. A relatively young person, as you can see here. There is an eye of the penetrating eye injury 16 years earlier. There was a removal of the foreign body. However, the endothelium was compensated for some time, and only 1.5 decades later, it was starting to decompensate, causing central corneal edema. So this is what we got preoperatively. Vision is 30%, IOP is normal. However, there was a big variability in the keratometry, and that was assessed by IOL master. You see here almost 8 diopters of astigmatism. The cornea is very thick, obviously due to the edema. This is the left eye on the left hand picture, and you see that the central cornea is having average thickness of 698 microns. The different machines giving us different, sometimes confusing results. Here is the OCT, one of the machine we used, showing us 3.3 diopters of astigmatism. However, this is another machine which is IOL master, and the IOL master was showing us clearly that 2K is providing us 8.12 diopters of astigmatism. So we've got a bit of confusion with regard to the IOL power calculation. So we decided to use the second eye as a reference because we were not being able to measure the cornea absolutely precisely. So here, the technique of graft preparation. Graft preparation is done with the murine punch, basically with the murine technique. I love this technique and use this all the time. So you trephine the cornea from the endothelial side, and then the idea is to separate the endothelial layer with descemet membrane from the underlying stroma, while the cornea is placed with the endothelial side up. So by staining the inner part of the cornea, so it is possible to visualize the mark made by the trephine. And basically there are 2 leads that will be used later on to strip the descemet from the stroma. And right now I'm removing the peripheral portion of the descemet membrane and completing the cuts, creating the leads. It's very important to be sure that there are no peripheral adhesions, and for that it is a good idea to use spatula to detach the descemet membrane. And sometimes you can see there are some tags, and you definitely need to tear them off, otherwise they will break the descemet. So this is my technique. I'm pulling the descemet membrane, and at the same time I'm placing some drops of the dye on the stromal side of the cornea. So this allows me to detach the descemet membrane and to stain it at the same time. So, and then the same maneuver is done with the second half of the graft, and is shown here. Again, I'm tearing and staining the cornea at the same time, so there is no need to stain it. So then the next step is to create the triangular mark, which I will be using for orientation of the cornea. So this is asymmetric triangular mark that gives you idea of the orientation of the graft. I love to remove a strip of peripheral descemet membrane, because usually this is the area where the descemet of the bare descemet membrane, because of the tripine, you removed and compressed all the endothelial cells. So I love to have this complete endothelial layer. So, and this is done in pretty much in the way that we do destemetorrhexis, and it's very, very easy, and even much easier than the destemetorrhexis. So the graft is prepared, and now it's time to do the surgery, the actual surgery, as shown here. First of all, I will mark the area of destemet stripping, which will be in that case 8 millimeters. And I like to remove the corneal epithelium, because to my experience, the dystrophic epithelium delays the healing response that happens postoperatively. So it's better to remove the damaged epithelium, which is located now at the center, used to be located at the very center. Having irregular cornea, it's a good idea to use methyl cellulose to smoothen the surface, because it's becoming a little bit irregular. The next step is to inspect the area of the zonular defect, because with the trauma like that, so you don't really know what's happening with the zonules. However, when I started to do capsulorhexis, the lens was pretty stable, meaning that there is no massive zonular defect. However, there was a localized zonular defect, not very much complicating the removal of the cortical material and the lens, because they both were quite smooth. And now it's irrigation aspiration of the cortical material, and hydrophobic acrylic lens is being implanted into the capsular bag. And it's time to suture the coloboma, because I would love to have it sutured to avoid any optical phenomenon that may happen in that patient postoperatively. 10-0 polypropylene on a long needle is used to suture that post-traumatic coloboma with the Sipser sliding knot suture technique. I'm sure you're all familiar with that, when one of the loops is externalized through the main incision, and then the second portion of the suture is externalized, and the knot is tied outside and then introduced back into the anterior chamber. The tips of the suture were cut, as shown here, and following that, it's time to make a coloboma. I like to create coloboma with a sharp bent needle, which I introduced from behind the iris, and I puncture the iris close to the periphery, and I use the Sinskey hook to expand the coloboma a little bit, as shown here. So this is a very nice 6 o'clock located coloboma that will help me to prevent the pupillary block due to gas tamponade. Descemet membrane is stripped from the posterior surface, and I see there are some adhesions in the area of the post-traumatic scar, where the stroma was damaged during the impact caused by the intraocular foreign body. So I need to strip off this residual strands of the stromal tissue, and then it's time to remove the viscoelastic. And when I was removing viscoelastic, I realized that it's not really a strand of the corneal tissue, but vitreous coming through the coloboma. So obviously we need to remove these vitreous strands, otherwise they will not allow us to effectively attach the destimate membrane. So the idea here was to place the second suture and to completely close this coloboma, which was not initially planned. However, I believe that this maneuver helped me a lot to block the vitreous and to avoid further prolapse of the vitreous strands through the coloboma and through the damaged zonules. Luckily, the damage of the zonules was very much localized, and there were no further issues with that. So now the coloboma is completely closed with the second suture. And at that point, I'm using cohesive viscoelastic, which is now should be removed from the anterior chamber. And following that, the graft, which is located now in the cannula, in the glass cannula, is introduced inside the anterior chamber. I like to immediately suture the wound, although it's not too wide, only 2.5, 2.6 millimeter wide. Anyway, there is a chance of the graft to be lost when excessive pressure is built. So I like to suture the main wound and do my graft expansion immediately after the suturing. So luckily the graft was in the correct position, which was verified with intraoperative OCT, not presented here. And as shown here, here is the mark. You see, this is triangular mark on the edge of the graft, showing me that the graft orientation is perfect, exactly what I was planning to get. After some efforts to center the graft, it was fixed to the posterior layer of the stroma with a gas bubble, and that was the end of the case. And obviously I placed the contact lens because there were no epithelium. There was a need to avoid patient adverse sensation. Postoperatively, in the early postoperative period, there was a gas bubble, was not possible to measure the visual acuity. However, 2.5 months later, we've got very good visual results. However, there was a hyperopic shift in that patient, 1+5 diopter with some cylinder due to this peripheral corneal scar. And obviously, this was the reason of this hyperopic shift, that we were not being able to measure this cornea preoperatively very precisely. So this is how the eye looked, and this is the edge of the graft, as you can see here. And in that case, you see that the cornea was a bit flatter than we expected it to have based on the measurements from the second eye. The astigmatism was 1.2 diopter, which was not very significant. However, there was a bit of miscalculation that happened in that particular case. And I thank you very much for your kind attention.
Thank you. Great. Any questions from Dr. Attenborough, Professor Gabizon? Any questions?
Boris, just a question on DMEC. We all thankfully do a lot of these amazing procedures. I find it quite difficult when the anterior chamber is really deep in a patient that's had posterior surgery, when the patient is vitrectomized, for example. Do you sometimes err on the side of caution and do an ultra-thin DSEC in these cases? Or are you brave enough to try and very carefully unfold a DMEC, knowing that the anterior chamber can sometimes be absolutely massive and we struggle a bit?
Yes, Michael, I agree that the excessive deepening of the anterior chamber might be a challenge because with the attempts of flattening the chamber, you have to make the cornea not only flat, but like concave. And that happened to me recently. Sometimes you really cannot predict that because it's only not only based on the depth of the chamber, but on the status of the zonules. And if the zonules are very weak and the iris is also kind of atrophic, so there is a tendency for not necessarily this is the eye that was previously vitrectomized. So it sometimes happens with the regular eye. So I'm not a DMEC cowboy, and I think that it should be used in a very good eyes with very nice anterior segment structure, which is not altered. And if I have some concerns, I really like to use DSEC because I understand that even if I can do DMEC, sometimes some repeated rebubbling or endothelial damage due to a lot of manipulations will not be beneficial for the patient. So I think we should really have DSEC and DMEC in our armamentarium and try to use them wisely in a very specific cases. And I think it should be a balanced, a well-balanced approach, and not the trend to use either this one or that one, because I've seen some surgeons doing DMEC in vitrectomized eyes, aphakic eyes, whatever it is, you name it, any eye.
Wow.
Yeah. And I really admire this nice technique, but but practically speaking, on the daily basis, I think these efforts are great, but too much for me. Too much great for me.
One thing that yes, definitely DSEC is may be used. There's also a trick that we can use is a matrix suture. You can use a pollen, a 10-0 pollen suture that you use in the anterior in the anterior chamber. You use 6 passages of 10-0 pollen, and this matrix suture will hold your graft. And it's much easier to do in vitrectomized or very shallow anterior chamber. So it's very elegant to do DMEC in these cases with matrix suture in the anterior chamber.
It's a great, really great. So tell us a little bit about this suture.
Yes.
How do you do that?
Yeah, so you use 10-0 pollen with a long needle that you turn a bit, you 1/3, 2/3, and then you place this suture in the anterior chamber, and you go 1 passage, a second one, and you do 6 little passages, and it's very easy. Before inserting your grafts, then you insert your graft. When I saw that you use the cannula, the goiter cannula. So you insert the goiter cannula on top of your pollen sutures, you inject carefully your graft, being careful to orient it well with a little edges, so you know that you're in the correct orientation. Then you, like you do, you close the incision, and then you not tight the suture, but you tense the suture, and then the area between the prolonged suture and the corona become flattened, and then you can do it exactly like you do in flat anterior chamber.
Oh, interesting. And then you remove the suture at the end of the surgery, or next day, or few days later?
It's interesting. So in DMEC, I definitely remove at the end of surgery. You just cut and you remove it, very easy. But for DSEC, I use for aphakic eyes, I do the same technique for DSEC, and I can let one prolonged suture that I suture, and I remove it a day later.
Someone from the audience says it's called the masked basket technique.
Oh,
I was not aware of the name.
We published that. We published that in Saphir nearly 8 years ago. Sophie Stephan, we won the prize of the Saphir. I think it was 9 years ago.
Okay.
I see there is a second. I see there is a question from the audience as well. So it's to you, Michael Attenborough. What is your minimum corneal thickness that you would not attempt DALK? Is there a minimal thickness that you will not try DALK?
No. Normally, if you have, it's more of how much of the cornea needs to be removed. But some patients, we will do DALK on a very irregular cornea, because we're trying to correct the irregularity. Some parts of the trephination could be 300 microns, other parts could be 750 microns. And I think that's where we massively helped by the amazing anterior segment OCTs we have available these days, because we can do a 360-degree analysis of the area we're going to trephine. So we always want to keep our trephination depth to the minimum thickness, because obviously you don't want to perforate. But I can't recall in my past if there's any minimum thickness for DLK. I don't think that's a number that we need to know.
Alors, just a comment, the minimal thickness that you can select with the adjustable trephine by Moria is starting at 2, so 2 microns.
Oh, I see. Yeah. So those marks are they're each calibrated in 100 microns, halfway between being 50 microns, and a quarter of the way 25 microns. It's very accurate. And I've done so much OCT analysis of post-operative cuts. Often in the early months, you have peripheral graft swelling, so it's difficult to measure exactly. But you can get it down to 25 microns with a quarter of those numbers. So and what's nice is that the adjustment ring does not move because you don't touch it. The second that you turn it over, nothing moves, and it's always good to check it once or twice. But once you set the depth, it stays like that. And you don't need to count your amount of turns. Once you rotate your dial and it hits the stop, it will stop, and it's very, very accurate. So about 25 microns, I say, is this level of accuracy.
I would like to add. So I agree with Michael that there is no minimal limit for the dog, but there is a minimal limit for big bubble, because you need some stromal tissue for the big bubble to form. So sometimes it's a bit mixed. DALK and big bubble is different. So you definitely can do DALK with the mechanical dissection, and there is no minimal limit for that. But obviously, if the cornea is like 150 microns or around that, I will definitely don't attempt the big bubble, and there is a limit for that.
I actually had that experience last week where I got a double bubble. I had a type 1 and a type 2 bubble. So frustrating. because
you lucky one, you know, it's so rare.
Yeah, so I managed to collapse the one bubble onto the other bubble and turned it into a type 1, thankfully, but it's very scary because it's so thin. But it was my fault actually, because like you said, my initial trephination was probably too deep, and I did a big bubble into only 100 microns of cornea.
Okay.
Okay. So I think if there are no other questions, I cannot see any.
No, apparently
So
no.
I would love to thank all the speakers today, Michael, Eric, James, for great talks. And I personally learned a lot, and I will be definitely using some of your tricks in my next surgical days. And that is a great thing of these webinars. And I thank Moria for joining us all together and to be able to share all these nice techniques and personal tricks. Thank you very much.
And thanks a lot from Moria to all the speakers and to you, Professor Michaud, to moderate this webinar. Thank you
it was
very
a pleasure.
much.
Thank you. Have a wonderful weekend.
Thank you.
Bye.
Have a good weekend, everyone. Bye-bye.
Bye.
Bye.
Thank you.